oblate design, I just want to familiarize yourself with the different types of RGPs that we have. So I think we all know the corneal design very well. This we've been fitting for years now. With corneal lenses, those diameters are usually between 8 to about 12.5 millimeters. And with corneal lenses, the weight of that lens bears entirely on the cornea. So the different types of RGPs that we have is we can classify them according to their lens diameter, and also that is based on where the lens bears the weight as well. Then the other specialty lens that we're quite familiar with is scleral lenses. So scleral lenses are around 15 to 25 millimeters in diameter, and for these lenses, all of the weight bears on the sclera completely. So these lenses are designed to not touch the cornea at all. All of the weight lands directly onto the sclera. And then somewhere in between corneal and scleral, we have corneal scleral lenses. And this is what we're going to be talking about today, but specifically in an oblate design. So corneal scleral lenses come in prolate designs, which we have been using for keratoconus for a while now. But in the last few years, the oblate design is actually becoming quite popular, even in non-grafted corneas. So these lenses are about 12.6 to 15 millimeters in diameter, and here the bearing is distributed across both the cornea and the sclera. So the weight of the lens is shifted both over the cornea and the sclera. So some of the indications for oblate corneoscleral lenses would be typically your post-graft PRK or LASIK patients, or any patient with an oblate-shaped cornea, such as in cornea plana. So these are usually flat corneas that are flat in the center and steeper out in the periphery. And now recently we found that we actually use it quite often with peripheral ectasia as well. So instances where we get too much central clearance with scleral lenses because the cone, for example, in keratoconus, is out in the periphery. The fitting philosophy behind an oblate lens is a little bit different to what you would find with a scleral lens or with a corneal lens for that matter. So with the fitting philosophy with an oblate corneoscleral lens, we want to have at least 20 to 30 microns over the lumbus. So very thin kind of clearance where the lens kind of just floats over the lumbus. The landing zone of the lens lies inside of the lumbus, so it doesn't land on the lumbus. It still lands on the cornea just inside of the lumbus. And then in terms of clearance, we want to have at least 50 microns, so not quite as much as scleral lenses where we need about 200 microns. With oblate lenses, we only need about 50 microns over the highest point over the cornea. And then the other important thing with this is that we want to have the edge of the lens parallel to the sclera so that we still maintain some sort of tear exchange, which is also quite different to a scleral lens where it fully vaults the cornea and doesn't allow for any tear exchange or very minimal tear exchange to happen. And what is important here is that the choice of your base curve is controlled by the highest point on the cornea. So you would choose the base curve of this lens by clearing off that highest point on the cornea. So this is the 6-step fitting guide to fitting oblate lenses. And I know this is a lot of words and it looks very overwhelming. So I don't really like to talk through words. I actually prefer to teach using examples. So we're going to go through each of these steps while we work through a case, and then it'll be a bit easier to understand how to achieve each of these steps as we fit a patient. This screen, though, I do like to have all of the fitting rules on one page, so you can actually take a screenshot of this, so that when you start fitting these lenses, you have everything, all of your steps on one page, so that it's easy to refer back to. All right, so let's go into our first case study. This is a tomography map from the Pentacam of our 51-year-old male. He had a history of keratoconus. Now, if you look at these maps, you can see they're very irregular cornea. So he had keratoconus, but he had a graft. All right, so he had both his eyes grafted. This is just an example of his right eye. And even with having a corneal graft, he still experienced vision that wasn't functional enough for him. So he still couldn't carry on his daily tasks. So he needed something to help him get to functional vision. So whenever I talk about my keratoconic patients or patients with irregular corneas, there's something that as optometrists, I think it's innate in us to always want to get to 6/6 vision with all of our patients that we have. And what we just need to bear in mind is that when we get involved with specialty lens fitting, with irregular corneas and keratoconus and grafts, we have to come to the realization that chances are we may not get to 6/6. We may not get to our gold standard vision. So when I talk about VA and vision with my patients, I talk about 6 happy vision. What is going to make my patient happy and functional? What are their job? What is their job? What do they do day to day and what kind of vision would they need to do their jobs? And you would know that with everybody, not everybody needs 6/6 to actually function or survive. Some people, 6/12 is actually perfectly fine for them. So you need to find out what are your patient's needs and what are you both working towards to. So you all set realistic outcomes before you even start fitting a specialty lens. All right, so moving through the steps. So with this particular patient, this is a grafted eye. I want to work through the fitting steps with a grafted cornea because this is what the lens design was intended for. So I can show you how you would fit it according to the fitting rules. And then after we get through the grafted eye, then I'll show you how we used it in the case of keratoconus. That was not grafted. All right, so this is our patient's eye. You can see the graft post-junction over here. You can see all the stitches are out already. So his eye looks pretty good to get started with fitting contact lenses. The lenses that I'm going to talk you through is the Rose K XL Oblate fitting set. I don't have any financial disclosures with Rose K. This is just the only Oblate fitting set that is available in South Africa. But it would work on similar principles. So whichever Oblate lens design that you choose to use, that company would perhaps have its own fitting rules, but the fitting philosophy is universal. Okay. So according to their fitting set, when we are selecting the base curve, we basically have to select the flattest base curve that gives us full clearance over the highest point in the cornea. Now, with corneas that have been grafted, that highest point is usually somewhere around on the host graft junction. So where the host tissue joins the grafted tissue, somewhere along that point, that's where you would find the highest point of the cornea. And it can be anywhere around the graft. And that's why these corneas make it quite difficult to fit with prolate lenses, because this point is usually part of the periphery. And that's why oblate lenses work much better for grafted corneas. So with their fitting rules, if you've got a post-graft patient, they would say go 0.3 millimeters flatter than the mean K, and then it gives you steps for different types of things that you're working with. So if it's radial keratometry, there's another rule. If it's post-LASIK, then it's another rule, and so forth. And then it says, if you have no measurements to start off with at all, then you can start with a base curve of 7.8 and you can work from there. So basically you put the lens on the eye and from there you will decide whether or not you need to get more sag or less sag. So with this particular patient, this is a post-graft. So we're going to follow the rule that says 0.3 millimeters flatter than the mean K. So we go to our topographies. Just bear in mind as well, when you're fitting specialty lenses, you don't need to have fancy equipment like the pentacam or a keratograph. It's really nice to have, but you don't have to have it. You can still get away with just a manual keratometer. So even if you had a manual keratometer or an autorefractor keratometer, you can still get the flat K, you can still get your steep K, and then you can calculate your mean K from there. All right. So with the pentacam, the mean K is calculated for us, and according to this measurement, it is 7.28, which is basically 7.3. And according to the rule, we would fit 0.3 millimeters flatter than the mean K. So our first lens of choice here is going to be a 7.6. So this is all the lenses that come in the oblate fitting set. If I go down to a 7.6 base curve, the sag is 4,367 microns. So we take this lens, put it on the eye, and then this is what I see with the OCT. Again, you don't need fancy equipment like an OCT. It makes your life easier and it makes you get through your patients faster, but you can also make these evaluations using a slit lamp as well. All right. So if you're using a slit lamp, you would basically just use your slit beam. You do an optic section, and you would compare the tear thickness to the lens thickness. These lenses are about 200 microns, 200 to 300 microns. Again, you'd have to check with your manufacturer what the thickness of their lenses are, and then you can compare your tear thickness to the lens thickness. All right. So with this particular lens, the first trial lens that we put on according to step 1, central clearance, I got 127 microns, which is fine, but that's not what's important to me. When I'm fitting an oblate lens, I want to go to the highest point on the cornea and make sure that there's at least 50 microns under there. So for this particular patient, the highest point was around 10 o'clock. And when I did the OCT here, I found that the clearance was actually very little. This was about 10 microns. So I realized this is not going to work. We're going to have to increase the sag. We're going to have to get a bit steeper with the base curve to allow more tear layer in between the highest point and the lens. Okay, so we need to increase the base, we need to make the base curve steeper and increase the sag. So we would need to go to our next steeper lens, which will then be a 7.4. So we don't need a huge amount of clearance, just a little bit. So we're only going one lens steeper. So in this fitting set, you'll see that the base curves goes in 0.2 millimeters. So from 7.6, we had to go to a 7.4, and this increased the sag by 100 odd microns. All right, so increased sag, and what did that look like? So we put it again onto the eye, and we go over to the highest point. This is a better shot of the highest point with the OCT. Here you can actually see where the join is between grafted tissue and host tissue here. Okay, so here's the highest point in the cornea. And if we look at this clearance, much better clearance now. So this is about 100 microns of clearance, which is a little bit more than what we need. But just bear in mind, there is still going to be some settling of these lenses because this picture was taken as soon as we put the lens on. Give it 3 or 4 hours and it might still settle a bit more. So you always want to see a little bit more clearance rather than a little bit less clearance. Essentially, the clearance moved up to about 200 odd microns. So that's still fine. No issues there. So this was our second trial lens after insertion, and the clearance over the highest point of the cornea is looking good. That means we can move over now to step 2, which is to look at the periphery. All right, now with the periphery of the oblate XL lenses, or the corneoscleral lenses, this is quite important because remember it fits quite differently from a scleral lens. With these lenses, we do want to see that the edges of the lens kind of floats over the sclera. We don't want it tight onto the sclera. So we do want to see this fluorescein band around the limbus. That's what we're aiming with the periphery. You want to see at least 1 millimeter of fluorescein just beyond the limbus. So if you look at this whole picture from the center going out, we've got green everywhere, which means there's no touch over the cornea. At the point where the cornea goes quite high, at that junction, you can see that it's a little bit black here, but with the OCT, we could see there was still clearance under there. So even though it looks like it's touched, it's not really touching. There is about 100 microns of clearance under there, and it is fully going over that high point. The fluorescein around the limbus, that fluorescein band, is about 1 millimeter, so that also looks quite good. In the fitting set, they actually provide you with the diagram so that you can compare your picture that you're seeing with your patient to their diagrams of what the different fits are. So diagram A shows us what an ideal peripheral fit is, where you've got this 1 millimeter band of fluorescein just beyond the limbus. And if I look at my patient's fit, I can see the same amount of fluorescein all the way around as well. So for me, this periphery looks pretty good. But if it didn't look this good, say for example, we had excessive edge lift, meaning that there was too much fluorescein. Can you see here all the way around the limbus? That band of fluorescein here is more than 1 millimeter. Then you could easily adjust the edge lift. If it is too much or an excessive edge lift, you would basically ask them to decrease the edge lift for you. So depending on how much fluorescein you see here, you could ask for either a -1 standard steep lift or decrease. You can either say decrease the edge lift or make the edge lift steeper, meaning that you want to get rid of some of this fluorescein. And then if there's an insufficient edge lift, like we have in this diagram, where you can see that these edges are starting to dig into the sclera, then you can actually ask them to flatten out the edge lift or increase the edge lift for you. And then in that case, you would ask for a standard flat lift or a standard increased edge lift. So basically, in the fitting set, they will have these diagrams to show you how the lift should be and compare it to the picture that you're getting with your patient so that you can decide, is it ideal, is it excessive, or is it too little? Okay, so this slide basically explains what I've just said now. So if you've got excessive edge lift, you can see this is more than 1 millimeter of fluorescein all the way around the limbus. So we definitely would want to decrease that edge lift. And then here you can see that this is the ideal peripheral fit. We've got a 1 millimeter band of fluorescein all across just beyond the limbus here. So this is what we would leave as a standard fit or standard lift. And then with very little edge lift, like here where it's very tight on the edges, we would want to flatten out that edge to get more fluorescein under there. Step 3 and step 4 you can evaluate together. So step 3 being the diameter, we usually want to see about 1.3 to 1.5 millimeters of the lens beyond the limbus. So if we look here, there's the limbus, and here's the edge of the lens, and you want that amount to be approximately 1.5 millimeters on either side. All right, and then this comes in with location as well, because we want to see that this lens is nicely centered all the way around the limbus. Now we all know, so this looks quite nicely centered. It's maybe slightly a little bit here to the nasal side. This side looks a little bit bigger than this side, but it's still fairly well centered. You'll find though, when you fit oblate lenses on keratoconic corneas, there are times where you'll find that the lens does decenter. Slight decentration is not too much of a problem as long as your patient is still getting good clear vision and if they're still comfortable. The only thing that it may cause is that if it's decentered too much, it may cause a little bit of discomfort. It may also cause a little bit of glare or halos if the optic center moves over the pupil. But usually with these size lenses, we don't have too much of those issues in terms of it decentering that much where it would cause glare or halos. If you did want to improve the location of the lens or the centration of the lens, you could actually ask for a larger diameter lens if need be. Okay, so that is in terms of location. So diameter, just something to remember with the diameter. This again can be adjusted. The normal diameter of the fitting set is 14.6 millimeters. You can make it larger or smaller. If you're uncertain though, always rather leave the lens a little bit larger in diameter than going too small. Right, so some of the fitting tips that come along with the fitting set is that you if you need to, you can decrease the diameter to assist with insertion and removal. So if you've got very small palpable apertures that you're dealing with and your patient has very tight lids and they can't get the 14.6 millimeter lens into the eye, you can get it made a little bit smaller. But when you have the lens a little bit larger, it actually does often make the lens more stable on the eye. So you do want to try to avoid making it too small. Bear in mind that if you are changing the diameter, a small change, even a 0.3 millimeter change, can make a significant difference in terms of how the lens stabilizes on the eye. And if you do change the diameter, you don't have to worry about changing the base curve because it doesn't have any impact on the base curve. Unlike with corneal lenses, when you change the diameter, you also have to change the base curve as well. You don't have to do it with these lenses. And like I said earlier, if you are in doubt, rather leave the lens in a larger diameter than in a diameter that's too small. Step 5 is then on movement. So with movement, like I said, with these lenses, you don't have that complete vault over the cornea. You do actually want to see a little bit of movement because there is some tear exchange with these lenses. So you need to judge the movement of these lenses as soon as you put them on and also after they've settled for about 20 minutes. So when you first put the lens on, you want to see about a half to a millimeter of movement, and you can judge this when your patient looks up and blinks. Then you'll be able to see how much movement is there. If there's about a millimeter of movement, that's perfect. If there's too much, you would have to adjust it. And you would adjust it like how I had mentioned in terms of adjusting the periphery. So you would make the edge a bit tighter. If there's too little movement, then you would obviously want to make the edges a little bit flatter. And then after you've judged that initial movement, you let the lens settle for 20 minutes. And then after 20 minutes, you should see at most a half a millimeter of movement. There shouldn't be too much more than that. That half a millimeter of movement just ensures that there's some tear exchange under there and that the lens is floating over the eye, basically. That movement can be judged, or the edge can be judged with slit lamp, but if you do have an OCT, you can also judge the landing of the lens with the OCT. So if we're looking at the edges of this lens under the OCT, this is the temple edge, you can see it's landing on the sclera quite nicely. It is digging in maybe just a little bit here, but not too much, but on the nasal edge, also landing quite smoothly as well. Okay, so here's a picture of a lens, or sorry, a video rather, of a lens that has settled on the eye. And you see, as the patient looks up, this is the ideal amount of movement that you would want to see after the lens has settled for about 20 minutes. It's just that very slight half a millimeter of movement. Okay, so we've got good movement here. We've got that fluorescein band all the way around the limbus. And that's how we know that the edge of this lens is good and that it's landing nicely over the sclera and it's still allowing movement of tears under the lens. Okay, other things that would also help you judge the peripheral fit is your patient comfort as well. Your patient would complain if there's too much movement. So exactly like a corneal lens, if there's too much movement, your patient will be uncomfortable. And then also if the lens is too tight, you'll find that your patient's going to have difficulty removing the lens by the end of the day. Okay, so going back to my patient with the grafted cornea, at the 1 month follow-up, this is what the lens looked like. So again, we still had that full fluorescein glow under the lens, with it getting just a little bit thinner here at the high point. We had the fluorescein flush around the limbus, which meant the periphery was still good. And if we took a closer look, okay, sorry, before we take the OCT look, just to compare it with what their ideal base curve looks like. So the picture on the left here is the picture of the patient that I fitted, and the picture on the right is the patient is the ideal base curve fit, and what it should look like from the fitting guide. And if we look at the two, they're fairly similar. Just for my patient, it does come a bit close on the high part of the cornea. So when I looked a bit closer, because when I saw this, it did look a little bit dark with slit lamp. So I just wanted to make 100% sure that it wasn't touching the cornea. Just remember with fluorescein fluoresces when it is thicker than 20 microns. So if you have fluorescein that's thinner than 20 microns, it's going to look black. You only get that green fluorescence if that tear layer is thicker than 20 microns. So even though it looks black here, and it looks like there's possibly touch, if we look at the OCT image, it's still a very thin layer of tears in between, okay? Which is fine because remember this lens is completely now settled. When we had put it on initially, there was about 100 microns of clearance. Obviously, with time, that will settle. Bear in mind, corneoscleral lenses do tend to settle less than scleral lenses because they're lighter, so they're not going to settle in as much. But also, you have to think about how squishy the conjunctiva is of your patient. So if you have a patient that has a very squishy conjunctiva, you can expect more settling to happen. And if it's a fairly stiff conjunctiva and sclera, then probably a little bit less settling. But this is why we always leave sufficient space between the lens and the cornea to allow for that sort of settling to happen. All right, so when we had a look at this after a month, this is what the lens looked like, and centrally, that clearance reduced to 214 microns, which I was also happy with. So for me, this was still looking good. Patient was comfortable, had good vision, and there was no staining under the cornea after taking the lens out. Right, and then the last step is the power of the lens. So when you're determining the power of the lens that you need to order, Always do your over-refraction in a trial frame. It gives your patient a more natural feel, and it gives you a better over-refraction as well. What you do need to remember is to keep in mind your vertex distance. So whatever power you find in the trial frame, if it's over 4, remember to convert that before ordering the power of the lens. And if you do end up with high amounts of residual astigmatism, you can order these lenses with a front surface toric design. So you can compensate fully for their astigmatic residual astigmatism that comes through. Okay, and then this basically just gives you an idea of what we had achieved with this patient. So unaided VA was hand movement, best corrected vision with spectacles was 660, and when we fitted the oblate lenses for this patient, we actually got him down to 6.6 vision. Right, so with the next case, this is where I used, because I was getting such good success with the oblate lenses with my grafted patients, where those high points are out in the periphery, I thought, okay, let's try to use it on some of the keratoconic patients that we're having problems with scleral lenses. So this particular patient, he has keratoconus, as you can see from the side profile here, very obvious. And you can see from his tomography map here as well. And you can see that steepening is happening quite peripherally. Okay, so quite inferior. This cone you can see is quite inferior down out towards the periphery. You'll also notice that this patient also has albinism as well. Okay, so keep that in mind when we're looking at the VA outcome for him. He has albinism as well as keratoconus, so he has a lot of other issues that we had to consider in terms of his vision. So initially for him, because he's got keratoconus and because it was so severe, we went straight into scleral lenses for this particular patient, like we usually do. It was a locally manufactured lens, and we started off with a 4,000, or not started off, this was actually the final scleral lens that we landed on. So after fitting all of the lenses with the scleral lenses, this was the parameters for the final scleral lens. So this was the only lens that kind of cleared that cone. I want you to note here the SAG was 4,600 microns and the power was a minus 1350 diopters. All right, very big prescription, and it only gave him a 3-line improvement. All right, so this is where I said just keep in mind he's got albinism as well. So for him, moving from 240 to 648 was actually a huge improvement for him. So he was very happy to continue with some sort of specialty lens to help him see. Even though it wasn't a massive improvement, it got him to functional vision. So he was still happy to continue with this. The problem with this was the way the lens fitted. So like I said, his cone is quite inferior. And as we can see here in the OCT, there's some scarring. And with the scleral lens that we put on, we got 260 microns clearance over this cone, which was sitting here at the bottom, which is fine because that's what we actually need. We need about 200 to 300 microns of clearance over the highest point over the cornea. What was the problem with him is that centrally we got 762 microns clearance. Okay, this is a massive amount of clearance and a little bit too much, because this amount of clearance, this excessive amount of clearance wasn't just over the center, it was over most of the cornea. And only over the cone, which was at the bottom end, that's where we got 200. So for me, that didn't look very good. And this is also the reason why we had a minus 13.5 diopter prescription as well, because we had such a thick tear lens. And when we looked at it with slit lamp, you can see this lens just doesn't look very good at all. We've got very tight edges. We've got lots of limbal clearance. And we can see that by this conjunctiva having this very popped up appearance. All right, so even without the fluorescein, even if you just had to look at this straight on, you can see this is not fitting well. And this was our best fit we could achieve with the scleral lens. So I thought to myself, okay, we've got 700 microns of central clearance. That's far too much. At the bottom where his cone is, we're getting 200 microns, which is what we're looking for. So how can I decrease this 700 microns of central clearance, make that area or make that part of the lens come closer to the eye but still maintain full clearance over the cone, which is lying here at the bottom. And that's what I thought an oblate is. That's exactly what the shape of an oblate is. It's flatter at the center and steeper out in the periphery, which is exactly what I wanted. So I thought, okay, let me try to put an oblate lens onto this eye. So with the oblate lens, now, because we're using the oblate lenses for a purpose that is basically off-label, because it wasn't designed for keratoconus, it was designed more for flat corneas and grafted corneas, there's no fitting rule per se for that particular eye. But the case or the fitting set does say if you don't have any measurements, you can start with a 7.8, put the lens on and see what happens. For this particular patient though, because I had fitted scleral lenses with him and I knew that 4,600 micron sag was what we landed on with sclerals, and I wanted to decrease that a little bit, what I had done was I looked at the fitting set and I saw what was the next lens that had a slightly lower sag than that, because I knew I wanted to decrease my sag. So the next lens in the fitting set was a 7.6 base curve that had a sag of 4,361 microns. I'd like to draw your attention here to the power of the lens that turned out to be -1 diopters. Okay, so I'll show you the fit now, but just keep this in mind, that from the scleral lens that was a -13.5 diopters, we eventually ended up with a lens that was a -1, and I'm going to show you why. Again, only with that 3-line improvement, which for him was great because it got him from non-functional to functional. So when we put this lens on, over the highest point of the cornea, we got 65 microns, and remember, with an oblate lens, we want to see at least 50 microns after settling. So it cleared the cornea cleared the highest point in the cornea quite nicely. Centrally, we were still seeing quite a bit of clearance. It was 591 microns, still quite a lot, but it was still better than the 700 odd microns. But what really made a difference was the way it looked on the eye. So compared the oblate lens on the eye compared to the scleral lens on the eye. Huge difference. So just to go through the parameters again, we had decreased that sag quite a bit, and the eventual power that we ended up with after over-refracting was -5 diopters that got him that 3-line improvement versus the 13.5 diopters. So just by bringing the central part of the lens closer to the cornea and decreasing that central clearance, we managed to have a huge impact on the power of the lens. Okay, we decreased it quite significantly. And also changing the design, the way that the lens landed on the sclera looked a lot better as well. All right, so this is looking at the oblate lens with the fluorescein and without the fluorescein. You can see here this has a much better look than what the scleral lens had. And obviously we checked periphery, we checked movement, and everything looked good. Initially, when we put the lens on, this is the movement we saw. So you'll see this movement is a little much. Okay, but this was before we had let it settle. Okay, I just wanted to show you here what the movement with these lenses look like. Okay, you can see there's a lot more movement. Also with keratoconic and patients with albinism, they are very photophobic. So apologies for the slit lamp image not being great, but I did try to hold his lid up there just to show you what kind of movement we get. And that tear exchange, you can see the tear exchange under the lens with the bubbles moving across. All right, so I'm still busy with this patient refining the final lens. We may still decide, he's had it now for a month, we may still decide to change the edges if it hasn't settled yet, but we'll make those decisions at the aftercare visit. But for now, this lens brought this patient from being a low vision patient to a functional vision patient with the oblate lenses. All right, and then on this slide, I just have a few fitting tips for you that, again, all in one paper or one page, so you can screenshot this and have all of this information at your fingertips. It's everything I've already discussed, but it kind of just summarizes a few of the important points that if you need to just refer back to quickly, you've got it all on one page. All right, and then that's the end of my presentation.